So before I start this presentation, I would just like to acknowledge all of the co-authors of this clinical statement that were listed here. And I'd like to thank Julian Legg, who was the driver of this clinical statement with John Simpson, who really got it to publication, because we started this in the middle of COVID, and it is an amazing statement that I hope is going to be really useful and improve standards of care for individuals with learning disability. And it is a particularly interesting group of patients that could be challenging that I saw quite a few of at the Brompton Hospital. So before I talk about the management and what the statement showed, I'd like to go through a few definitions to set the scene. So when we look at a learning disability or an intellectual disability, it's the preferred term that's used in the UK to refer to individuals that have a significantly reduced ability to understand new or complex function information, to learn new skills, and a reduced ability to cope independently. And this starts before adulthood and has a long-lasting effect on their development. And when you look at the term learning disability, this is also echoed in other countries. So it's not, although it's the preferred term in the UK, it's not just UK centric. We need to remember that individuals with learning difficulties represent a wide heterogeneous group of people and can be associated with a broad range of primary diagnosis. So, for example, an individual with Down syndrome will have a primary diagnosis of that, but they will have subsequent comorbidities, for example, cardiac insufficiency, obstructive sleep apnea. And when we look at learning disability, it can be really quite mild. So you might have an individual that just needs some help on a day-to-day basis, but functions and can live fairly independently. But at the other end of the spectrum, we have those that have a profound learning disability, and that can have multiple learning difficulties on top. And those can be just as challenging as some of the ones with mild disability. Now, if we look at the prevalence, it's really hard to get a definitive record of the number of people with learning disabilities. And it was looked for the BTS guidelines in England, but actually when you look worldwide, there is no register. So if we look at the estimation of people that are effective, it's around 2% of the adult population it's estimated to be, and 2.5% of children are potentially living with learning disability. And I'm just going to go through some facts about individuals with learning difficulties. They have a huge burden on healthcare needs in the general population, because about 50% of people with a learning difficulty will have at least one significant health problem. They're 20 times more likely to have epilepsy than the general population, and a higher prevalence of psychiatric illness in children and adults compared to the general population. Along with that, there are higher rates of dementia. They're more likely to have visual impairment and hearing impairment. They're more likely to be underweight or obese, and that those that have eating and drinking and swallowing difficulties are likely to have a 40% chance of dysphagia, which experiences recurrent chest infections. So why is this important? Why has there been a call to improve healthcare and healthcare provision for those with learning disability? Life expectancy in this population is reduced to the general population. And if you look, 37% of adults with learning disability live beyond 65 years of age, whereas normally you would expect that to be 85% of the general population. So that's a marked decrease compared to what you would expect to be. And when you look at the causes of death amongst adults and children with learning disability, bacterial pneumonia accounts for 24% of adults and 21% of children's deaths. Aspiration pneumonia comes into play in 17% of adults and 3% of paediatric deaths. And when we look at community-acquired pneumonia, which is the purpose of the statement, which encompasses bacteria pneumonia and aspiration pneumonia, it's a major contributor to an increased hospital risk. And those that have had an episode are at risk of increased repeated episodes secondary to their community-acquired pneumonia. So it's a massive factor in mortality of this population. So this is a really simplified diagram and states the obvious. Community-acquired pneumonia happens outside the hospital, and it can be as a result of a bacteria, a viral infection, or aspiration of the abdominal contents. And the purpose of this statement is to provide preventative measures to prevent people getting community-acquired pneumonia, but also to look at early detection and identify those patients at high risk so that we can provide a proactive management plan for them and reduce the mortality from all avoidable causes. So prevention actually should start in primary care, so via the GP. And in the UK, as in other countries, this usually involves an annual health check, and this is available for those individuals over the age of 14 with learning disability. And the aim is to minimise the amount of health inequalities that they experience. The long-term review by the GP should look for long-term conditions and identify the risk factors for community-acquired pneumonia, which would be amenable to intervention. And just before I highlight those risk factors, I'm just going to say that individuals with learning disability should receive their annual influenza vaccination. They should have their pneumococcal vaccination as per the national standards, and that they should also be considered as a high priority in vaccination for all of the programmes for seasonal respiratory infections. So they're high priority for the COVID vaccination. So our annual health checks should look at the risk factors, and the risk factors for community-acquired pneumonia include sleep disordered breathing, a history of respiratory infections, reduced mobility and impaired motor function, unsurprisingly eating, swallowing and drinking difficulties, gastroesophageal reflux, because again that has a high potential to aspirate, hypersalivation, poorly controlled epilepsy. We know this population is 20% at higher risk of epilepsy, but we know that epilepsy in itself predisposes an individual to potentially aspirate. And also we know that sleep disordered breathing factors into poorly controlled epilepsy, and that if there is low oxygen saturations, that can also be a problem. We've got issues around bacterial colonisation, immunodeficiency, those individuals with tracheostomy, oral health, if that's poor, again, that can increase the bacterial load and predispose people to community-acquired pneumonia. We've talked a little bit about nutritional status in this group anyway, but smoking, environmental tobacco smoke exposure, and the presence of comorbid conditions. And for the purpose of the rest of the presentation, I'm going to focus more on those that I've just highlighted. So let's start with sleep disordered breathing. Again, I've said that this is a heterogeneous population, and we can have individuals with neuromuscular disorders that have learning disabilities. And we know that when the vital capacity is less than 60% predicted, the incidence of nocturnal hypoventilation has been shown to increase. So we should be screening for this, particularly in neuromuscular diseases. We also know that low lung volumes can predispose people to atelectasis and impaired ventilation. We have those that may have symptoms of obstructive sleep apnea, and they may present with excessive daytime sleepiness, habitual snoring, witnessed apneas, gasping, choking, nocturia. I think that we've missed out a key thing here in that children often with obstructive sleep apnea may present with hyperactivity rather than excessive daytime somnolence. So that's just something to be taken into account. We've got symptoms of hypoventilation, so the excessive daytime somnolence, morning headaches, poor concentration, reduced performance at school, challenges in behaviour, and reduced appetite in the mornings. We know that people who never obtain or lose the ability to walk due to a progressive neuromuscular disorder will have a sign of severe muscle weakness. And again, severe muscle weakness in general, or a population that isn't ambulant, is an indicator again that they might be predisposed to sleep disordered breathing. And then we've got specific conditions like Down syndrome, where 30 to 79% of children are likely to have obstructive sleep apnea, and in the adult population that has an even higher prevalence. So we should definitely be reviewing and monitoring their sleep using at least oximetry. And then we've got Prader-Willi syndrome due to the potential increase in weight, but also other parts of the condition and disorders in drive that would predispose these children to having a potential sleep disorder, and that they should also be monitored. So the guidelines recommend, not just in the neuromuscular population, but because we know that decreased lung volumes lead to sleep disordered breathing, that spirometry should be measured as part of the respiratory assessment. And it may be that this is particularly challenging because the individual doesn't have the cognition to take a deep breath in, to blow out and as hard and as fast as they can. So what we might need to be doing is looking at coaching and looking at a slow vital capacity. So other methods that we can get an accurate measurement of the vital capacity. But of course, there are some individuals that is just not going to be possible. So if there is any suspicions, that they should undergo overnight oxygen measures. And if you saw an oximetry trace just like this one in the red with the oxygen levels significantly dipping, that would be, as a screening tool, an indicator that this should be investigated further. If you've got the transcutaneous carbon dioxide levels, and this is in kilopascals, so we're looking at anything above my arrow that I'm wandering across the screen, so anything above 6.5, and you can see that this one's hitting at least 10 kilopascals. So this is just not oxygen desaturation due to upper airway obstruction, but we have an elevation in our carbon dioxide levels indicating that this patient has hypoventilation rather than just obstructive sleep apnea. Now, this is a paper that was around decision making to limit treatment in life-limiting or life-threatening conditions in children, and it was more around looking at all of the decisions, but also whether to start ventilatory support in the intensive care environment. But I think that because we have such a wide heterogeneous population, that the principles of treating in the best interest of the individual come into play. And there has always been some ethical discussions that may go around whether the treatment that you're going to provide, is it appropriate for that individual? So we have the individual who is, of course, centre of the care and what we're going to do. Within that, we'll have the family considerations and the clinical considerations about whether ventilatory support or CPAP treatment should be commenced in this individual. And what we're looking at is, are we going to increase the individual's life expectancy with improvements in their quality of life and restore normal apnea? And if that is the case, then providing respiratory support in these individuals is treating in the best interest of that individual. However, if someone is so profound and towards the end of their life, actually, are we going to be treating them in the best interest, or is that treatment going to prolong suffering for that individual? and that we won't restore normocapnia and we won't provide any benefit. So we've got this balance. So we have our sleep study, and there are options for us. You can either do nothing. If they have obstructive sleep apnea, we can treat with CPAP therapy. If they have nocturnal hypoventilation, we can treat with non-invasive ventilation. And if that's not appropriate, but we need to palliate symptoms, we can think about using oxygen therapy. Now, going back to the guideline, to the clinical statement, what we stated was that if obstructive sleep apnea is identified, there should be an assessment for any potential causative factors like adenotonsillar hypertrophy, upper airway hypertonia, and that should have a careful appraisal of all of the treatment options, bearing in mind the risk-benefit factors. Children and adolescents should be referred to the ear, nose and throat specialist for an upper airway evaluation and consideration of surgical management. A trial of CPAP therapy is indicated where surgical management is deemed to be inappropriate, or if they have been treated surgically, the obstructive sleep apnea persists despite this surgery. Regular follow-up is important once the CPAP has been established to monitor adherence and the efficacy of treatment and to optimise the pressure. Non-invasive ventilation is indicated in the presence of nocturnal hypoventilation or hypoventilation, raised CO2 levels. And clinically stable patients can be started either at home or in the hospital setting, wherever is deemed the most suitable for that individual. Again, once it's established, the individual should have a sleep study to ensure that settings are correct and that they should have subsequent reviews, and that the assessment of their ventilatory support should include efficacy, adherence, and review of the interfaces. So prior to actually doing that, there are the practicalities of providing CPAP therapy or non-invasive ventilation in this group of patients. And what we need to do as clinicians is we need to engage the therapy to the person and introduce the treatment at their comprehension level. And again, it's about the fact that you may have introduced a mask, you've spoken to the patient, and for example, they want to go into space, or space is something that's really important to them, or they want to be a fireman, if their level of comprehension is of that age. So you make up a story, you tell them that they're going to be able to use this to practice, it's going to be like a fireman's mask, and you build up their confidence, and they can put the mask on and they can go through that journey of being the person or subject that you've identified for them. And it may take time to slowly build up the amount of time they can wear the mask, that they allow you to attach the device and build up the pressures. And often it may be that you need to actually pause and come back and do refreshers. It may be something that doesn't happen overnight. However, if someone is fairly symptomatic and they feel better for using it, they will continue to use it, and it will be adopted as part of their normal regime and routine. And the purpose for that is that CPAP or NIV may reduce the rate of respiratory exacerbations in patients with poor secretion management and frequent episodes of community-acquired pneumonia. So that's why we're doing it. When we look at respiratory tract infections, previous episodes of community-acquired pneumonia indicate, as I've stated earlier, subsequent risk for community-acquired pneumonia. And if we take the cerebral palsy population, respiratory admission is associated with a higher than 50% likelihood of further hospitalizations in the following 12 months. And that has a massive impact on that individual's quality of life. So we know that we should be carrying out spirometry, but in addition to that, we should be looking at whether we can get a cough measurement. And again, there may be some issues around whether that is going to be an accurate measurement. From a sort of level of the forced vital capacity, if it's less than 75% predicted, it can indicate impairment in cough strength. And also, if the cough peak flow is less than 270 litres per minute, patients should be referred to a specialist respiratory physiotherapy for cough assessment. Now, we have our normal cough assessment. And depending on the impairment of the individual, it may be that we can carry it out. We can ask them to take a deep breath in, and they cough. We can look at it. We can ask them whether, and their carers, whether they can clear effectively. We can look at the rise and fall of the abdomen. We can listen to the clarity of it, and we can ask them to say E. But there are a large group of patients that will not be able to cough to command. They may not be able to communicate with you, and you've deemed some information from their relatives, care team, whoever comes in with them. But you look at them and you can hear upper airway gurgling. You might find that they're orally suctioning to try and clear everything that's in the mouth in order for it to sound better. And that over time, their cough reflex is just desensitized. And they're able to sit quite comfortably with a lot of secretions just sitting in their upper airway. As I've said, you ask them to cough, that's not going to happen. You can look to stimulating around not the inside of the ear but the outside of the ear with a cotton bud, and that might stimulate a cough. You might perform a tracheal rub to try and stimulate a cough to see what it looks like. Now, those patients you may find that when they do cough and they clear and it is effective. But the problem around the cough is this desensitization and that they're not coughing enough. Or you may have those that have a weak cough and that's ineffective. And it's the fact that you can't go down your simple sort of your normal way of thinking, like I've put on this slide here. So if an individual has a history of respiratory tract infections, the recommendations are that you should try and get a measurement reading. And if you can't get a measurement reading around their cough strength, and regardless of that, they should be seen by the respiratory physiotherapist for cough assessment, and where indicated that they should have a tailored airway clearance regime for them. And we're going to talk about airway clearance regimes in a moment. Mechanical insufflation exsufflation is the treatment of choice in those individuals with neuromuscular diseases to enhance cough efficacy. And people with learning difficulties who cannot clear secretions with conventional treatment, so breathing exercises, manual techniques, should be considered for positive expiratory pressure, mechanical insufflation exsufflation devices, or high frequency chest wall oscillation, or intrapulmonary percussive ventilation. So what we looked at was splitting the patients into different groups. So you tend to see those patients that have an inability to cooperate and may have severe bulbar impairment with the secretions, as I explained, just sitting in the proximal airway. You have those patients with learning disabilities but also have a weak cough, and that may be due to severe, but in this instance do not have severe bulbar involvement. You've got retained peripheral secretions, so secretions sitting at the outside, and they're fatiguing. And you have retained peripheral secretions in those that aren't fatigued. And then you've got secretions that patients are unable to participate with what we're being asked to do. So if we have a patient who has the inability to cooperate and severe bulbar impairment with secretions sitting in the upper airway, as I've mentioned, suction may be the treatment of choice in order to orally clear the secretions, or nasopharyngeal suction. And it may be that getting some air behind the secretions, either via a lung volume recruitment bag or a simple ambu bag, or delivering a deep breath in via an IPPB device, will facilitate the secretions moving and for you to be able to clear them. If we have retained proximal secretions due to a weak cough without bulbar involvement, what we're looking to do is to assist the cough. And that can be via giving deep breaths in via a piece of equipment that delivers a deep breath in, by providing a manually assisted cough, so helping the expiratory phase of the cough, combining the two together, or considering a mechanical insufflation-exsufflation device. Where we have secretions that are in the outside of the chest and that the patient is fatigued, we're going to need to consider providing some ventilatory support, or whether that treatment itself provides ventilatory support. So if the patient is severely fatigued, it may be that treatments occur in conjunction with non-invasive ventilation or an intermittent positive pressure device. You may add in manual techniques to loosen the secretions, or add in, if that's not working, a vest device or a high frequency chest wall oscillation device with non-invasive ventilation to mobilise the secretions. Or in the acute care setting, you can consider the metaneb, which may provide some ventilatory support, or IPV, depending on what your local provision is. For those individuals that are less severe, that aren't experiencing weakness, we can look to mobilise peripheral secretions with more simple things like postural drainage, with and without breathing exercises, depending on how much they're able to participate. If they are able to participate, encouraging deep breathing, the forced expiration technique, coughing, can be a very simple and effective way of doing that. And I think that we shouldn't forget exercise and the importance of exercise, and getting people moving actually moves secretions, naturally encourages deep breaths, especially in individuals who may not be able to process. I want you to take a deep breath in. Just getting them to try and lift up their arms, sit to stand from the chair, all of that can move the secretion so that they can be coughed and cleared independently. And then when that doesn't work, what we're looking at is using positive expiratory pressure, either via a PEP mask or a mouthpiece PEP device, or oscillatory PEP devices, as shown here in the bottom left of the slide. And if they don't work, then there is some use with using expiratory flow acceleration devices, and these can be particularly useful in those patients that also have difficulty cooperating, where they're breathing through vacuum technology, which increases our expiratory airflow bias and moves secretions, as per the other techniques, towards the upper airway. And in those patients who have retained peripheral secretions but are unable to participate in treatment, they should always have a suction machine available to them, and you should have one readily available just in case whether high frequency chest wall oscillation, manual techniques and positioning, or mechanical insufflation exsufflation shift an overwhelming amount of secretion that you can't clear, that they can't clear, and you need to assist. Alluded to exercise being a key way of mobilizing secretions, but it's not just about exercise to clear secretions, it's about encouraging our patients to be as physically active as possible in order to prevent community-acquired pneumonias. We know that individuals with learning disability have a wide spectrum. So you will have those that are able to walk, you will have those that are able to do sit to stand. And we know that the benefits, the mass benefits of exercise, I don't need to tell you them. We're told that we need to exercise to maintain joint movement, positive attitude, improve our lung function, cardiovascular fitness. So this isn't just, this shouldn't be limited to individuals without without learning disability. But the difference is that the programme should be tailored to the individual, and it may be that the community physiotherapist is the best person to do this. It's not my expert area, but I am going to touch on the antibiotic side, because often coming into clinic, one of the questions that either the care team or the local medical team ask is, should this patient, because they're at risk of recurrent chest infections and community acquired pneumonia, have prophylactic antibiotics? And currently there isn't any direct evidence to say that they reduce the severity of community acquired pneumonia in people with learning disability. However, really excitingly, there is the Parrot trial running at the moment, which will hopefully give us the answer to that. But on the basis of risk benefit and taking into account the evidence base from bronchiectasis and cystic fibrosis, it is deemed that patients with frequent episodes of community acquired pneumonia should receive enteral antibiotics and may be considered for optimisation of modifiable risk factors, appraisal of individual circumstances and frequent infections, and the degree of the neurological impairment, and the parental views. And if that is the case, azithromycin, if there are no contraindications to it, are the preferred enteral prophylactic antibiotic in this population. And in patients with frequent episodes of community acquired pneumonia who have colonisation, for example, of Pseudomonas aeruginosa, a trial of long-term nebulized antibiotic considered, but a challenge test should be performed prior to starting that. And clinically, I found that when we've had patients who are colonised with Pseudomonas, that actually commencing antibiotics seems to have reduced the severity and amount of infections. As I've said, if we're trying to prevent things, we're also looking at excessive saliva. And I think that in the statement, there is this beautiful table that talks about the different interventions and also the advantages and the disadvantages of them. And it's a really good resource because we're never quite sure exactly what we want to do and what will work best. So I'm not going to go into detail on it, but there is a really good section on excessive oral secretions. With these individuals, it's always important that they have escalation plans or care pathways in place, and that is highlighted throughout the document, because what we never want to do is end up having to have those conversations if they're acutely unwell in hospital. If we've got all of that information before us, that can be really pivotal to their management. So let's now, we've talked about preventing these, trying to prevent community acquired pneumonia by decreasing the risk factors and the modifiable things that we can change. But if someone's got it, let's have a look at the management. So first of all, what we want to do is we want to assess the severity of the community acquired pneumonia. And there are different ways to do that. So in the adult population, looking at the CURB-65 severity score and the CRB-65 and the CURB-64 severity scores. And in children, we can look at a severity assessment, which was adapted from the management of community acquired pneumonia in children. Both of the scores are taking into account respiratory rate, and in the paediatric ones, we're looking more at what else is happening. So, for example, whether we see mild recession, involvement of our accessory muscles, and with regards to other factors that can indicate severity in children that otherwise are not necessarily applicable to the adult population. And once we've worked out our severity, there is a risk stratification. So patients that are at low risk and have scored a low risk score, that have a low mortality, they should be considered for home management, and that's not surprising, in conjunction with the clinical judgment and review of social circumstances. and that the oral and enteral antibiotics should be prescribed according to the local and national guidelines. However, if you're at moderate risk, then you should be admitted to hospital. And again, the antibiotics that are prescribed should be as per the local or the national guidelines. High-risk patients, hardly surprising, should be admitted to hospital, and they should receive intravenous antibiotics as per local national guidelines. So, clinical practice points for individuals are that a chest radiograph should be performed in all adults requiring a hospital assessment with suspected community-acquired pneumonia. And also it should be considered in children and young people with features of severe or complicated pneumonia. In individuals with mild to moderate community-acquired pneumonia, blood testing and microbacterial investigations, including sputum culture, sensitivity and blood cultures, pneumococcal urine antigens, should be undertaken to help guide treatment. In those being assessed for community-acquired pneumonia, they should have pulse oximetry carried out, and it should be used as an adjunct to look at further investigation and treatments. And all of those in hospital should have an early warning score, and for the UK, that tends to be the news too. As we've said, antibiotic therapy should be guided by severity and what is being grown. For those who have community-acquired pneumonia, who are young adults and children, supplementary oxygen or high-flow therapy should be considered. And what you're doing is you're targeting oxygen saturations at 93 to 98%. And adults should have their oxygen saturations targeted between 94 and 98%. But those who are at risk of hypercapnic respiratory failure should have their oxygen saturations targeted between 88 and 92%, as per other guidelines around provision of non-invasive ventilatory support. And a key factor is that patients who have retained secretions, because community-acquired pneumonia tends to be surmised that it's a non-productive pneumonia, but these individuals with learning difficulties have other problems that may involve retention of secretions, and so we need to have the early involvement of the physiotherapist to assess them and instigate a regime. Now, I've talked through earlier the treatment options that are available, and they are similar in the acute setting as to what you would potentially start to prevent and to keep the airways clear. So I'm not going to go over them in massive detail, but again, within the guideline, there is the evidence base over, for example, in this part, manually assisted cough, and that there is a good evidence base in neuromuscular disease, and we have neuromuscular patients who have learning disabilities. We can also, as we've said, provide support by supporting the inspiratory component, and we can use mechanical insufflation exsufflation in these individuals. What was interesting, however, was that the device has been evaluated in cerebral palsy, and although it didn't show any benefit over conventional physiotherapy due to it being a small study, it did sort of clinically start to edge on that there may be some signal that this could be useful in this group of patients. As stated, we've got conventional physiotherapy, we've got postural drainage that we can use, and despite the fact the evidence base is non-existent for this, using these techniques clinically on the ward has proven to be of use in this group of patients. We've got breathing exercises, and we've got PEP and oscillatory PEP, which can be used in the milder learning disability population. It may be that in individuals that aren't able to cooperate or that are on ventilatory support, chest wall strapping can just change lung volumes and help to mobilise secretions upwards. And interestingly, there is evidence in individuals with cerebral palsy to show that expiratory flow acceleration devices are useful at clearing secretions and decrease hospitalizations in that group of people. So to summarize, I think that we'd be here all day if I went through the whole of the guidelines. So I hope I've given some key takeaways, which are more towards the severer end of the scale of individuals with learning disabilities. But the clinical statement is a great resource for managing this patient group and can provide you with some key information. The identification of patients at high risk is key, and then holistic management and modifying anything that potentially is modifiable in this patient group is key, because that prevention and early intervention will hopefully prevent hospitalizations or severe episodes of community-acquired pneumonia. Everyone is completely aware that anticipatory care plans are key, and that they provide a key resource about the individual, but prevent confusion around escalation of treatment and what is appropriate and what potentially works. I've highlighted that a detailed treatment options for community-acquired pneumonia are highlighted throughout the document, and obviously that takes more reading and digestibility. But I think that it's probably quite hard to see if you're on a small computer, but again, go to the original resource, in that it will tell you the risk factors, it tells you identify what the problem is, and it tells you the solution beautifully. So I would like to stop there and thank you for your attention, and I know that we're going to open the floor to questions, but I'm just going to highlight that there are 2 surveys going on at the moment about mouthpiece ventilation and also monitoring and non-invasive ventilation. And even if you're not an expert in the area, there are appropriate questions to ask you what you would want. So thank you very much for your attention. And I've just been also asked to highlight that the next webinar is actually on a Friday, the 24th of February, and Dr. Patrick Murphy will be talking about non-invasive ventilation in obesity hyperventilation syndrome.
Thank you very much, Michelle, for a nice overview on the prevention and the management in this patient population. We have a few questions in the chat here. The first one is, based on your clinical experience, what is the number of patients that you treat with a learning disability?
That's a really interesting question, and the number of patients has been increasing over the years, for sure. And I don't know whether that's just because the Royal Brompton Hospital has a particular interest in managing these patients. But when you're looking at the whole population, it's probably around 10 to 15% of those that are requiring some form of ventilatory support. So it is increasing. And part of that is on the basis that there is a wide spectrum. Learning disability encompasses a lot of things. It could be termed that 1 in 50 people have a learning disability. But of the severer end of the group, what you're looking at is a 5 to 7% of the population, of the treatment population that we saw.
Thank you. As you highlighted, often these patients are immobile. Does exercise really help?
That's a really good question. And it reminds me of one individual who had a severe scoliosis, a really rare syndrome where, because that required him to have non-invasive ventilation, but because of the scoliosis and the chest wall deformity, his ability to walk was very limited. That said, his family had a treadmill for him, and he got on that treadmill and he walked every day, and the amount of hospitalizations and his stability after he adopted an exercise regime without anything else particularly changing was huge. He stabilized, he was fitter, he was requiring less hospital, he didn't come into hospital for weeks, and he just genuinely looked so much better in himself. So I think if you can find what works for that individual, you shouldn't dismiss someone because, oh, they don't look like they can walk very far. I mean, that might have been a sort of extreme example of someone doing really, really well, but there are things that we can think about that someone can do. And even in those that can't move themselves, so you're looking at the severe end, just rolling them, managing to put them on, if they're able to, on the big, I always forget the name of them, not being an MSK physio is terrible, but the big balls that you sit on and you bounce on and you move, and just getting movement through them, again, stimulates nice deep breathing, natural coughs, and can help clear things.
Okay, great. Another question came in. How do you perform a spirometry at a reliable and reproducible manner in this population?
It's really difficult. So there will be those that you can that if you're targeting at their intellectual and they're able to participate. Again, if you can see a ball going up and you've got really good trained technicians, or that you're good at it yourself, you can get a result that's reproducible, especially if they haven't got oral muscle weakness so that they can seal around it. But in those that can't cooperate, or that they find it much harder, you can aim for a slow vital capacity, and it's about the reproducibility in anything. You try a few times and you've got your best feedback and your best coaching, and you've targeted it at that level, then that might work. But there are some that you're just never going to get a reliable reading whatsoever. And so what you would want to do is sort of look at other factors about watching them. Do they naturally take a nice deep breath in if they're stimulated to? So does it happen spontaneously? Because whatever happens spontaneously will always be more, well, it's indicative of how they are, because it's happening spontaneously. Whereas if you're asking them to do something voluntarily rather than reflexively, you're always going to get a worse view of what's happening. Mm-hmm. But it's hard. It is hard.
Yeah. What airway clearance technique would be your choice in those patients that have issue with high tone?
That's a really, really good one, because often with some of the individuals, my airway clearance preference used to be moving towards high frequency chest wall oscillation, but just sometimes the vibrations can let everything settle a little bit, but often they can just increase the tone and make everything horrific. So for me, I've targeted those patients with an expiratory flow acceleration device, and it's just nice and gentle, and that can help move secretions. And as I said, the other techniques that you can look at and work with your neuro colleagues are ways to decrease tone and via exercise. So sitting on the ball, gently gentle movements can help to decrease tone, but also naturally then stimulate a deep breath in, and you might find that then triggers a cough that's effective and that then clears the secretions. But it's challenging.
Yeah. Last question here. Is community-acquired pneumonia a risk factor only for those children and young persons where either mobility is diminished in some way, or oral hygiene care is not optimal, or is simply having some sort of learning disability that prevents normal developmental and intelligence milestones from being reached an indicator?
Yeah, that's correct. So just
short answer. Okay, there are no further questions in the chat here. So once again, thank you very much, Michelle, for this nice overview and all the insights in the BTS statement. I think it's definitely worth a read.